Start by introducing myself. My name is Tyler Stoliker. I'm a family nurse practitioner. I'm trained in family medicine. I do mostly internal medicine and complex diseases in older people and younger people. Worked in the emergency department prior to that time. I'm going to introduce you.
No, I can introduce myself. Thanks. I'm his prettier looking brother, Brent. Just kidding. So I'm an optometrist. I work with Dr. Ryu at what's eventually going to be Valley Eye Care Associates. We're renaming it in January, actually. So if anyone was at the parade, we had those flyers out. We'll be changing our name, but I am a doctor of optometry. I did graduate from the New England College of Optometry in Boston in 2017. Done some residencies and member of a few different associations, but that's the boring part, so that's about me. So we'll move on to the good stuff.
So we wanted to talk to you a little bit about diabetes. November is Diabetes Awareness Month. It's something that's very close to both Brent and I. We both deal with patients with the disease, and we try to prevent the disease as that we can. I'm going to very quickly go through some of the types of diabetes. What is it? What's it about? Certain that probably most of you here have at least heard the term and may or may not know what it is. Some of you may have it. Diabetes, there are a few different types but the commonality among all the types is it's a problem with blood sugar. And with diabetes, blood sugar is too high, and there's a number of reasons for that to happen. In type 1 diabetes, this is a problem that your body and your pancreas simply does not work like it should. And the hormones that your body normally has to bring down blood sugar does not work like it should at all. And so we end up giving you medications like insulin to bring down your blood sugar. In the past, it used to be known as a number of different things, such as insulin-dependent diabetes. We now call this type 1 diabetes. In type 2 diabetes, it's similar, but this is a problem that your body still secretes some insulin. The issue is it's either not enough or it's not using it effectively. And so lots of patients with type 2 diabetes will have oral medications that you take every morning or maybe twice a day, or perhaps even use insulin for these as well. Once again, the blood sugar still remains too high unless if we treat it. There is a third type of diabetes that I'm not going to spend a lot of time on, that is gestational diabetes. This is what happens during pregnancy, and so all the men in the room can ignore me. Gestational diabetes, what's that? Gestational diabetes, for every pregnant woman, we do screen them for gestational diabetes. This is an issue that takes place only during pregnancy, and I'm not going to bore you with a lot more of the details, with the exception that if you did have children, if you're a woman and had children, if you had gestational diabetes, it does increase your risk for type 2 diabetes later in life. And so there's this last thing called prediabetes, which I really like working with in my office, because this is where your blood sugar is a little bit higher than it ought to be, but it's not high enough to be called diabetes. And this is the point at which we really want to work with you to help make some changes, maybe in your lifestyle, maybe in your diet, to help prevent the development of diabetes. So the real question is, why is this an issue? Why is this so important? And diabetes is extremely prevalent, unfortunately. The real problem is that it can cause a number of different secondary issues, with one of them being eye problems, which is why Brent is here to talk to you. But to just very briefly highlight some of the other issues that can happen with diabetes, you can have kidney disease that results from high blood sugar. Now, there are a number of other reasons for kidney disease, but it is one of the major factors in the development of kidney disease. You can have blood vessel problems. You can have what we call neuropathy, where you have pain in your feet, maybe, or pain in your legs, or maybe you don't have good sensation in your feet or your legs anymore. And that's an issue that your nerves are damaged over time by high blood sugar. And this can all be treated by treating your blood sugar if you have diabetes. There are some different liver diseases. Excuse me. In extreme cases, amputations can be a complication. This is oftentimes where the blood flow to your extremities is so compromised that maybe you get an infection in a limb and it will not heal because of the result of the blood vessel damage and lack of blood flow. So unfortunately, people will get toes amputated maybe, or even a little higher up, maybe the lower leg. We hope to not ever see that. Very briefly, the second part of diabetes in terms of healthcare is the cost. The majority of our patients over 65 are insured under Medicare. Some of the data that we got here is from the Centers for Medicare and Medicaid Services. At the end of the day, this is from 2012, so you can expect that it's higher than this now. I don't have newer data than this. $245 billion was spent in 2012 on diabetes alone. And so this is a tremendous cost, and both to you and to your insurance companies. That's actually a pretty interesting fact. Average medical costs for people diagnosed with diabetes about almost 2.5 times higher than people without. And that's out of pocket for you. That's medications, that's doctor's visits, that's whatever you need as a result of your disease. And so what are some risk factors? I already mentioned if you were pregnant and had diabetes during pregnancy, that is a risk factor. Age is a risk factor. The older we get, the more likely, or I should say, the higher the risk it is for the development of diabetes, particularly over 65. If you have a family member that has diabetes, that is a risk factor as well. And that's about it that I want to point out. All kinds of risk factors. So I'm going to turn it over to optometry.
Yeah. So now we turn to the fun part. What I do every day is I look inside of people's eyes to see if there's changes from diabetes. And it's kind of hard to wrap your head around, but the way I tell a lot of my patients is diabetes affects your body in 3 major ways that we need to monitor in order to figure out if it's getting worse, getting better, changing, or staying the same. And basically what we look at are the eyes, and Tyler would look at the kidneys and at the feet, and of course anything else that happens in the body. But we really are looking for the eyes and the kidneys and the feet in particular, because those blood vessels are some of the smallest in the whole entire body. And so because of that, anytime that the sugar inside of the bloodstream is too high, which is what happens in diabetes, it can damage that blood vessel. And those blood vessels we can only see without cutting you open to either look at your feet or to look at your kidneys by looking at the back of your eyes. So yes, you do have to come see me, and yes, you do leave with your vision very blurry because I've dilated your eyes and you can't see very well by the time you leave. But it's a very small price to pay when I don't have to cut you open or have Tyler cut you open in order to look at your blood vessels, right? So it's a fairly good trade. So what I do is I look at the back of the eyes and I see if there's any leakage or any swelling or any bleeding in the back of the eyes, and that's what we call diabetic retinopathy. So diabetic retinopathy is, not to bore anybody, it's literally just changes within the blood vessels of the retina. That's all there is to it. And the retina is just a light-sensitive tissue in the back of the eye. It helps us to see. It's what allows us to see. Glasses help you to see, yes, but sometimes it's not just your glasses. It's also what's happening in the back of the eye that could be affecting your vision. So once the light gets into the eye, it hits to the retina, and that's what helps you to see. Anytime that the blood sugar is too high, it can leak into the back of the eye and affect your vision in a way that even the glasses can't fix. And that's where I kind of step in. So I usually monitor those changes. Tyler will very frequently send me patients, and similar to Tyler, all sorts of providers around this community and the entire area of Northern Maine will send patients to me in order to dilate their eyes and look for those changes. So basically, diabetic retinopathy is the leading cause of vision loss in the working age population in the United States. And this boggles a lot of people's minds. A lot of people think that, cataracts is the #1 cause of vision loss in the United States in working age people. That's actually not true. It's actually diabetes. And so it's not cataracts, it's not glaucoma, it's not macular degeneration, it's diabetes. And so it's usually a little bit worse. The longer that you have the diagnosis, the longer that the blood sugar is as high as it is, the worse the bleeding will be in the back of the eyes. And that's a true statement for the entire body as well. Typically, the longer you have it and the worse control that you have over it, the worse the results can be as a consequence. And so basically what happens in diabetic retinopathy is those blood vessels will become leaky because the sugar in the bloodstream is too high, and they'll either leak fluid in the back, or there's simply not enough oxygen, and basically the blood that is in those vessels is very sludgy. It's not like a nice, I don't know, what consistency would you say blood is? It's normally like a watery consistency. It's more of like a gel-like consistency because it's full of this sugar, so it's very sludgy. And so it doesn't allow your retina and your eyes to breathe as well as they should breathe. And because of that, it can actually cause new blood vessels to grow inside of your eyes in order to supply that retina with oxygen so that you can see. The problem is those blood vessels are very fragile and they tend to leak very easily. And so they end up, this is a normal retina and a normal blood vessel. They end up, the blood vessels on the right, in a diabetic person, they end up bleeding all over the back of the eye and they end up leaking everywhere. And when I look at the back of someone's eye with diabetes, when it's very severe, the right picture there is what I see. Usually this person will come to me and they'll say, I can't see. And they'll say, I think I need to update my glasses. And my intuitive answer is, perhaps, yeah, you might need to change your glasses, but more importantly, we might need to acknowledge the sugar in your bloodstream. And the sad part is sometimes very young patients with like type 1 diabetes, typically is in a younger patient, they'll come to me and not even be aware that they have diabetes. I'll look at the back of the eyes and see bleeding all over the place or fluid in all over the place. And they end up being sent to Tyler because they need to have their sugars monitored. So basically symptoms, what you might see, changes to your vision. Now don't think that if you have any one or multiple of these that you have diabetic retinopathy. Any blurred vision, any flashes of lights, any floaters or little black spots or gray spots in your vision could be a sign of diabetic retinopathy. Decreased color vision and obviously the loss of vision. What can happen sometimes is you can actually have the blood vessels that stick to the retina, pull on that retina and almost want to tear it off, and that's what causes you to lose your vision. So it can be very, very detrimental. It does increase your chances of glaucoma, it does increase your chances of cataracts, and it does just make it a whole lot more harder on your, whole lot more difficult for your body to handle all of that extra sugar, which can lead to increases in stroke and heart disease. And that's really, getting back to the cost thing, one of the biggest reasons why it costs our country so much to manage this is because of all of the problems that diabetes can cause. So basically treatment, I'm just going to click right through those three. Tyler does the first two, and I don't do the third, and so I don't do anything on this slide. I basically will send you to Tyler for the first two things, either for insulin or for metformin or glipizide or glyburide or one of those medications that you normally take to control the blood sugar. And then if I look at the back of your eyes and I see that there's bleeding back there, usually that would require an injection. It's actually a shot in the eye, and nobody likes shots in the eyes, but unfortunately it's what's necessary to restore some of your vision. And I don't do that either. I simply look at your eyes and make sure if there is enough swelling there that I send you out to the appropriate person who does do the injection. That's usually an ophthalmologist who does that. So,
what is VEGF?
VEGF is a very scientific term. It's vascular endothelial growth factor is what it is.
Sure.
Yeah. Okay. Basically what that is, it's the chemical that triggers new blood vessels to grow in your retina. And so if you limit that, then the new blood vessels don't grow. And if the new blood vessels don't grow, then there's no bleeding or sweat or tearing of the retina because there's no new fragile vessels in the back of the eye. Yeah. So no problem. So this kind of leads us to, that's diabetes in a very quick nutshell. But I mean, what do you think the most effective medication is?
Exercise.
There you go. You hit it. So he said, this very intelligent gentleman here said exactly what the second word is here. Watching your diet and exercising accordingly. And that is not something that just Tyler or just a medical doctor or a nurse practitioner or a physician's assistant or an eye doctor, that's not just something that one person would tell you. That's something that no matter who sees you for the sugars and for the the diabetes that you have, we all need to be counseling and we all need to be educating you on how to better control your sugars. And the best way to do that is with appropriate diet and exercise. So
there was actually a study done, and I can't remember what year. I think it came out sometime around 2009 or 2010. And this study was basically set up to prove that metformin, which is, if you've ever heard of it, which is one of the most common medications used to treat type 2 diabetes. The study was set up to prove that metformin was the best thing since sliced bread in terms of managing blood sugar, and it failed miserably in comparison to the group of people in the study that got active and ate a healthy diet. It was more than twice as effective as those that were taking metformin. And so I'm not saying that medications don't have their place, they certainly do. I prescribe them all the time, so does Brent. But there's no question that the diet and exercise is the most controllable and certainly the less risk treatment for diabetes, regardless of whether you're on medicines or not.
And that makes sense, right? Because, I mean, anything, at the end of the day, it's not just diabetes that you'll control by having a good diet or exercising a lot. It's whole body health. It's your entire body that will feel better as a result. It's not, you're not just controlling diabetes by doing diet and exercise. You're helping your blood pressure, you're helping your cholesterol. That's stuff that he does, but it is all part of the picture. You know, it is still very important for whole body health. So those are our references. That's the boring part. What questions do you guys have?
At 93 years old,
Yeah.
I'm deaf and partially blind.
Yeah.
I don't have diabetes.
You don't have diabetes.
Good for you.
Well,
Good for you.
the last test was okay.
There you go.
You know,
Yeah.
just even though the older we get, the higher the risk for development of diabetes, it doesn't mean that you're going to have it. And there's a whole bunch of risk factors, like being overweight is one of the biggest risk factors for type 2 diabetes. There's plenty of people who are overweight that don't have diabetes. And so there's a number of other reasons for you to have kidney disease, eye disease, heart disease. That's not diabetes related. What we know, though, is that if you do have diabetes, that is a risk factor for these other things. And so kind of it's a two-way street.
But great for you. That's wonderful. Yeah.
Yes.
How high should it be?
How high should the blood sugars be?
Yes.
Well, so that's a loaded question. There's all kinds of factors that go into it. So my answer to you is a discussion with your doctor could tell you exactly how high yours should be. I can give you some normal parameters. Basically, a normal, quote-unquote, blood sugar when you've had nothing to eat or drink is less than 100. For patients with diabetes, commonly, somewhere between 100 and 130 is reasonable control. But not uncommonly do we say even a little bit higher than that would be okay, depending on what your other risks are, okay? So there's a whole bunch of ways to answer that question, and I hope that helps a little bit.
How low?
How low? So most clinicians will agree that blood sugars less than 80 are too low. And you're going to start feeling bad.
A while ago.
Hey, there you go. So blood sugars less than 80.
I was going to say, but now you've eaten lunch, so don't take it right now. It's going to be pretty.
Generally speaking, people will start having symptoms. Once they're less than 80, might feel a little jittery. They maybe feel tired or hungry. If it gets really low, they get sweaty. Any of these things can happen. And even in people without diabetes can have low blood sugar and feel this very same way. So that's why I'm saying actually talking to your doctor will give you the answer.
I tell my doctor that I'm not diabetic.
There you go. The reason is because the older, in my practice, I recognize that in especially our elderly population, low blood sugar is a high risk. If I make you too low, you might fall. And I don't want you to fall and break a hip. I don't want you to fall and get hurt in any way, because that would be horrible. And so we adjust what's normal depending on what your risk is.
Is diabetes a person can get more hungry or no?
It can. So sometimes if a person has really high blood sugar...
Could you just
What's
repeat
that?
the question? I don't think that they heard the
Oh,
question.
so the question was, can diabetes cause you to be more hungry? Is that what you asked, sir? Okay. So it can. Diabetes often comes without any symptoms at all. Lots of times I'll see patients come into the office that I just did routine blood work. I didn't have any inclination that something was wrong, but their blood work tells me that they have diabetes. Sometimes you'll have a person will feel maybe more thirsty, maybe more hungry, maybe they are urinating all the time, like they're going to the bathroom more often. Those are all signs and symptoms potentially of diabetes. Now, like Brent pointed out earlier, a lot of these symptoms overlap, and so just because you have those things does not mean you have diabetes. But yes, it's reasonable to think that might be a possibility. Yeah.
Okay, I need 40.
Anything else?
How about family history? How much weight does that have?
It has. it does have some weight. Family members with diabetes does kind of put up our antennas a little bit for, hey, how closely should we watch you? Now, the question is how much of it is genetic and how much of it is lifestyle, because oftentimes, and I think it's both to answer that question. Lots of times in families, you grow up in such a way, let's say you're a teenager and your parents both have diabetes. Well, is it because they have, unfortunately, not so great genes, or are they not active? Are they not eating appropriately? Are those factors influencing their diabetes? And so then if that is what you're learning to live by, and now you're not active and you're not eating healthy, does that increase your risk? The answer is yes. And so it goes both ways. There's
Is excessive eating of sugar, is it a sign?
excessive eating of sugar.
Yeah,
Well, that will definitely bring up your sugar, your blood sugar.
Yeah.
Over a long period of time, yes, could increase your risk for diabetes. When we think of adults with diabetes, we really think about resistance to insulin, and that is usually because of being a little overweight, but not always.
well, those who lack a lot of your sugar, it doesn't mean that you have a sugar. No matter.
I have lots of patients in my own practice who have really great genes and eat tons of sugar and are never active and they don't have diabetes. And I'm very happy for them. Because I know lots of people that would like that situation.
Yeah. And then I'm sure you see the opposite spectrum too, where you see the people who are very adamant, they're very close about what, they're very careful about what they eat, they're very rigorous really about how often, how frequently they exercise, and sometimes it's excessive, I would imagine. And they end up still having diabetes. And it's not just diabetes, they end up still having a lot of other issues that should have been controlled, and that, it's probably just bad genes. But like Tyler was saying, they would wish that they could be like that other guy who doesn't do a whole lot of work and just gets lucky and just doesn't have diabetes.
Do doctors know a lot of things about diabetes or not?
We do.
Yeah.
I'm one of them who know nothing about it.
And that's okay. Yeah, that's why we go to school for as long as
That's
we do.
right.
Yeah, we do know a lot. We have to know a lot.
There is so much more to diabetes than what we've told you here today. It used to be you'd take metformin or you were on insulin, and those were your options. This was, of course, years ago. There are so many other medications now, depending on what the problem exactly is, and how to prevent it, how to treat it when it's there, things like that. That every day we get smarter about diabetes. There's all kinds of research being done, and so I think that 20 years from now, the way we treat people is probably going to look a little bit different.
Does eating sugar is really dangerous?
In moderation.
Moderation.
They say everything in moderation, right?
Yeah.
So I have a question for you.
Yeah.
How often do you usually follow up with your diabetic patients?
Usually every 3 months. So for a person with diabetes, especially if it's poorly controlled, you can expect to see me in the office about every 3 months. If I'm changing your medicines, it might be sooner than that. So if you come in to see me and you have a new diagnosis, you've never had diabetes before, and all of a sudden I tell you do, I'll see you back in a week or two, probably to make sure that we can get you on the right track to managing this. If things are pretty stable, usually 3 months or so is what's needed.
That makes sense.
And blood work and all kinds of different stuff. You had a question, sir?
What kind of kidney disease could you end up with? I got a daughter that's in trouble right now.
Yep. So diabetic nephropathy is basically a term that describes all kinds of problems that happen in the kidneys, and you can end up with what we call chronic kidney disease, which is, if you think about what the kidneys do, the kidneys are kind of the filters of the bloodstream. So they kind of help get rid of wastes from out of your bloodstream, and you get rid of them and you flush them down the toilet. But if your kidneys don't work as well, then maybe they don't get rid of waste as well. And maybe they don't process medications as well. And so there are changes that need to happen to your medicines because your kidneys can't handle it anymore. There's all kinds of different things that can happen with the
I
kidneys.
was wondering if it could be diabetic or what, but she was diagnosed with, both her kidneys are full of cysts.
So renal cysts are different. That is not generally something that we directly associate with diabetes. Renal cysts are actually really common and usually are benign, but usually not diabetes. Yeah.
I had a kidney removed because of that. I had cysts on one of them.
Yep.
That turned out to be stage 2 cancer.
Yeah. Yeah.
That one's gone.
So that is completely different. The type of kidney disease that we think about is how your kidneys actually filter. That's the issue. More than structure, more than cysts and things like that.
But it's a filtering process.
all kinds of things that I could talk to you for 4 hours on kidney disease
Now,
alone.
listen,
You would all be sleeping by then.
Right.
Oh, I see.
That's right. So to kind of echo on my own question to Tyler, because a lot of people will ask me when I see them for their eye exams with diabetes, how often do I need to see you? And my very common answer is, I'll see you back in a year.
Yeah.
But that comes with limitations. I'll only usually see somebody back once every year. Like he says, he'll see someone every 3 months, and that's because he needs to monitor your sugars fairly frequently. Whereas I'm just making sure that hopefully you're at a point when I first see you where there's no issues with your eyes. And so hopefully every time I see you, there's still no issues with your eyes. So that's why I can see you, only every year. But that said, if there are changes to the back of the eyes, there is some diabetic retinopathy back there, I do see you sooner. I usually do see you every 6 months or every 3 months if it's very severe. Or if it's even more severe than that, then you're out the door to the guy that's going to help you with, the injections if necessary. But that's a whole different ball game. Yeah. Yeah. Anything else? Anyone else?
So I understand that they're looking into possibility of transplanting something into your pancreas
Yep.
if you're
Yes.
diabetic
Yep.
to help you produce insulin. How is that going?
Well, I don't know what stage that's at. I have heard of that as well. I think that's part of what I was thinking actually when I was saying I think 20 years from now, what we're doing for people might be a little bit different than what we're doing right now. And it's based on what research and what technology we have now versus what are we going to know 20 years from now. Especially, the cells that secrete insulin start with the pancreas. And so if it's an issue of the pancreas not working well, if there's some way for us to maybe transplant cells, maybe do something else to the pancreas that makes it secrete a little bit more, then maybe we can fix it. A lot of the medicines that we are using, so the oral medicines, are acting on basically one or two ways. They're either letting you use the insulin you already have better, more effectively, or helping you secrete more insulin from your pancreas. In both situations, your blood sugar comes down. That makes sense. So I don't know more specifics than that, but it will be very interesting to see what comes of that.
Okay.
It's incredible where technology is,
Oh, yeah.
where medicine
It's
is nowadays.
Yeah.
And I just graduated in May of last year with my degree, and I looked at the transcript of one of my colleagues who's going to be graduating in 4 years from now that just started school, and they're already changing some regulations.
Yeah.
They're already changing, things. So we have to stay on top of our own knowledge because it's always
Changes
changing.
every day.
Yeah, yeah.
Yeah, it is changing. I just got a continuous glucose monitor now.
Awesome.
So
Yeah.
I'm
Awesome.
now watching my blood sugar
There you
every
go.
4 minutes.
So one of the really cool things, not to take much more of your time, but cool, I think, for me, looking at it technologically, is one of the biggest things that's been talked about, at least through my office. We have a couple of diabetes educators that work with us. And for patients who are insulin dependent, so maybe in the past you would have given yourself shots, well, maybe now you're on a pump, an insulin pump that basically continuously gives you insulin to bring your sugar down. I think, my prediction, I guess, in the next 5 to 10 years is we're going to see, because it's already happening, these pumps are now working with these monitors.
Right,
And your body, if you take diabetes out of the question, has that loop already. So what's your blood sugar? Okay, it's too high. Pancreas give more insulin. It comes down. Pancreas stop giving insulin. I think what's going to happen in the next 5 or 10 years is we're going to have basically a device, like a pump, that works just like a pancreas that you don't have to do much for. That it's going to measure your sugar for you and dispense the correct amount of insulin for you and stop when your blood sugar starts to come down. It's coming pretty quickly. So that's pretty remarkable.
Yeah.
I think a lot of the complications that we've had, or not we, but in general, it's not hard to accidentally take too much insulin or actually accidentally take not enough. If you accidentally take too much, you risk running low, and you run low blood sugar. That can be quite dangerous. And so hopefully things like this continuous glucose monitor, which by the way I do all the time for my patients, it's becoming more and more in the forefront. Hopefully that will help prevent some of this and prevent injury as a result.
That it?
Thank you very much.
We thank you.
Sorry that we were a
Thank you.
little bit.
Thank you very much.
Thank you.
Really nice to meet you.